gente daqui, amor.
Obrigado, Bruno. Hello, Paolo. Hello, Carmen. It's a great pleasure to be here with you. Great honor, and thank you very much for you. And we hope to have a good discussion today. Thank you, Paolo. Thank you, Carmen.
Thank you, Sergio.
So we can start. So it's a really great pleasure to be here almost 1 year after we met together, not the last time, but the first time. And I will try to make a summary of at least what we found. And that's, I don't want to make a picture of whatever was published in this year, of course. But what we found, and it's, of course, then I'm very curious to have a discussion. So thank you very much, and I'm very pleased to share with you new ideas. Of course, no conflict of interest, and again, this was a very multidisciplinary team. This is one of the things that we learn in this experience, the multidisciplinarity in the treatment of COVID-19. And collaboration between different specialties. And I have to also to thank especially Professor Rocco, that you know very well from Rio de Janeiro, that she supported us a lot. This is, again, what was the first case that we had more than 1 year ago. And you see how we faced, how we treat these patients. Now, actually, is no more like that. We are more relaxed. Of course, we have protection, but not anymore. This kind of dressing, very light, only, of course, gowns, gloves, mask, shield, the FFP2, and cover the head. But we have no more any of such of this kind of dressing. So this is a big change. We are no more so worried as we were in the past. What we learned is that, and you remember this slide, that this was not only the pathology affecting the lung, but that affected different systems. And I will make some reasoning about coagulation that I think was a bit different from what has been reported. And of course, other organs, and especially the kidney, was an organ that we had major problems. The others, brain, yes, heart, so and so, liver, gut, but mainly the coagulation and the kidney. This is some initial data. You see that we got that among the patients who were hospitalized, almost 40% developed RDS, and all of them were initially treated with non-invasive mechanical ventilation or intubated, of course. So at the end, we got an ICU admission of around 20% of patients, and all of them in invasive mechanical ventilation. So our experience was, at least this is experience in San Martino Hospital, of course, was that we got all the patients in the ICU were intubated. The others were treated outside the ICU in the special areas. And the other point is that very few patients had septic shock or need of renal failure at the time of hospitalization and even ICU admittance. The hospital mortality overall at the time was around 40%, but then was around 35% in the 35% in the ICU, but we also collected, of course, patients very severe from all the regions. So around, anyway, in hospital mortality was higher at a certain point than the mortality in the ICU. This was curious. The fact, of course, associated with mortality were interleukin-6, we always measure in these patients. Probably this is to think in the future about corticosteroids. We don't discuss into detail, but we can discuss afterwards. Of course, the RDS development, the heart disease, previous heart disease was a negative factor, and of course, age. This is the survival probability according to the age. You see that very poor survival in older patients, and younger the patient is much better survival. So at the end, you see the survival probability 60% in patients between 60 to 70, while it improves a lot when you have less than 60. So our data suggests that, less than 60 survival is much better, and older than 80 survival is very poor, or older than 75, 70. This does not mean that at least we have to select patients, of course, but just to, I think this is also important to interpret the different data that has been proposed by different groups. This is another interesting issue that I'd like to share with you. We found that almost 38% of hospitalized patients with SARS-CoV-2, this is the cumulative frequency in the days after diagnosis, they had persistent viral shedding. So there was positive BAL or BAS, bronchoaspirate. So we are not talking about oropharyngeal. 40%, very high number in my opinion. And in patients with persistent viral shedding, immunosuppression, and increased interleukin levels were associated with longer length of hospitalization was outcome. So when the patient have a persistent viral shedding, this was associated with worse outcome. So this is an interesting issue open for discussion. This is another study. Is a large study, multi-center, just observational, just showing the evolution of mechanical ventilation. You see most of patients were mechanically ventilated. A minority was used non-invasive ventilation. And of course, you see that the probability to have mechanical ventilation is quite long. So this is the other thing that we learn after 1 year, that this is not is a disease that requires a very long time of mechanical ventilation. This is problems in terms of organization. In case we can discuss that. It's not only the number of patients, but also the length of ICU and hospital stay. These are some points that we just published. This is a sort of consensus, but just to make a summary, that I would like to share with you. So this is these are not my ideas. This is a summary of ideas of many people, and then I will show you some of our interpretation of them. So this is the common feeling that I think is nice to share with us. Awake self-proning. Now this was we also used. It was we wrote that awake self-proning may be considered and should be used when supplemental oxygen is necessary to maintain an SpO2 higher than 90%. We use awake self-proning. One issue, of course, is very helpful to as a rescue. When the patient is repositioned supine, sometimes you lose the effects. And our fear is to delay intubation. And I will show you now some data about CT scan. However, it's a good to do, in my opinion, if you need to do or to try. HFNO has been considered more and more. This is something changed compared to our first meeting. We use now more HFNO than the non-invasive. We have to define what is non-invasive, but HFNO we use more and more in the unit, outside the ICU. So this is changed because compared to the beginning, is more comfortable, very effective, and so we had a good experience with HFNO. Non-invasive. This is, I think, it depends what is non-invasive. We use the CPAP, but this is not helmet, but this is not a non-invasive ventilation. We did not use non-positive pressure. It was very difficult to do outside the ICU. And I can tell you, we did not use helmet positive pressure. So we just use CPAP. helmet, I know, you know that was a recent study from Italian group, but few patients, very difficult to do non-invasive ventilation by helmet outside the ICU. Tracheal intubation, these, of course, are the common thing. It should be considered when the patient is progressively deteriorating. It was suggested a lung protective strategy, of course, and neuromuscular blockade agents mostly in the initial phase. This is also what we did, but we try to use as less as possible, so for the shortest period as possible. Bronch ventilation has been used more and more. We used, I will show you again some few data. You know, several papers appeared, but if you look at most of the papers, many patients, they lose their positive effects when they are repositioned supine. However, in the early phase, we use prone position. For, I don't know if it here is written 16 to 24, we use 12 to 17. Recruitment in selective patients, of course, and ECMO. ECMO, I don't want to enter too much in this. We used ECMO. We did not get marvelous results with ECMO, I can say. And probably we use more as a rescue. I am the feeling that if ECMO is used in many patients very early, you get some more favorable results. But then I don't know if you can get favorable results also with conventional treatments. So our experience with veno-venous ECMO was not very positive, but we used ECMO mainly as a rescue. And I don't see how you could use ECMO when you are in the full-blown COVID-19 pandemic. You know what I mean? I remember when we were full of patients, impossible to organize 50 ICU beds with ECMO, at least in our unit. Weaning, of course, weaning should not be delayed. I agree with that. And pressure support trial was preferred as compared to other weaning strategies. Timing of tracheostomy, big discussion. I will show you some of data from our team. We performed a bit later, so after 10 to 14 days. And we use percutaneous. We then never use surgical. Corticosteroid, you know, dexamethasone, okay. We used, we like, again, you know that there were some studies also suggesting methylprednisolone. I think is an open debate. Anyway, corticosteroids, for sure, more or less. Even if corticosteroids are more infection. So I think the corticosteroids issue was probably finished too early at the discussion after the British study. Mobilization, of course, you know, we have here, Nemer and Guimarães, and of course we agree that the mobilization is very important, and of course maneuver for infection control. And of course, this is all these procedures was said that may be useful also for other evolution for cells. So this is what was published as a sort of summary, then eventually we can discuss some of them. One issue that was raised is the definition of Berlin. This is also new compared to the beginning, because we use more frequently the high flow. So the question is if we should include also the patient with high flow at least 30 liters per minute and up to a ratio below 200 in the definition of RDS that is not included in Berlin. I know that Carmen did several talks about the problems of Berlin definition, and I think that there are many issues that COVID-19 raises. So the cutoff for HFNO, if the latency should be increased, because we know that the complication may appear later than 1 week. If we should use other parameters like SpO2 FiO2, or even the radiographic criteria. So these are just some points that should be raised if the Berlin definition can be applied to COVID-19. This is another issue which is completely new. This is tracheostomy. This is a study submitted from our team. It's a multi-center in Italy. we found that median time of tracheostomy was around 15 days. And this is not randomized, but this is our data. Patients in which tracheostomy was performed, these are more than 450 patients, or many patients. You see there was no difference in the survival between late and early tracheostomy, and even there was no difference between surgical and percutaneous, but most were percutaneous in Italy. But some centers, they did surgical due to the fear of contamination. We did percutaneous. We are very experienced, but anyway, we prefer percutaneous. But anyway, our data suggests that there is no difference. And so why not to have an attempt of extubation or before to perform tracheostomy? And we found that post-tracheostomy infection complications were more frequent, of course, as in non-COVID patients in surgical versus percutaneous. So we prefer percutaneous, and we prefer a little bit delayed, not delayed, but just as we do in the conventional RDS. But it's open for discussion. Another problems that we learned is, this is just one study from the team of our infectivologists, including us, is the sobreinfection, a lot of sobreinfection after 12 to 14 days. And patient with VAP had a higher mortality. And the most frequent was Pseudomonas aeruginosa with Staphylococcus aureus. And then we had the more Candida auris, due to probably to the pressure of antibiotics. So these are some factors that we found associated. You see, with one model, we found the presence of septic shock at VIP onset, or the presence of RDS at the VIP onset, or other factors associated with mortality. But my concept here, I don't know your experience, but that there was these patients after 10 to 12 days, they have a higher risk of sobreinfection. And this becomes the problem of these patients. This is just one slide of another study that was done by our team with Chiara Robba and colleagues. Very large population of patients. Again, it's not randomized, but it's almost 1,100 patients. We compared, you know, there is a big discussion, of course, prophylaxis versus no prophylaxis. Prophylaxis is better, but I don't think this is a problem. We use prophylaxis anyway. The problem was if enhanced prophylaxis, so higher amount of enoxaparin or even heparin might be helpful. We found here that enhanced prophylaxis with a low molecular weight or heparin was associated with better survival. So this is our data, but it's open for discussion. And this was our protocol. I don't want to enter into detail, but just divided in the low risk, intermediate risk, according to the echocardiography and so on. What I mean is that we monitor with D-dimer, activated factor A, and TAG. And interestingly, this is the psoas echography. We found that when we developed hemorrhage, very few cases now, actually, we got more problem in the early phase. That's what we learned, what changed in 1 year. We were using at the beginning also to use anti-aggregants. We don't use anymore anti-aggregants, and we never had problems. This is just to remind the psoas, the echography of the psoas that you see here. And you see here, this is our echography, a normal psoas and psoas with hemorrhage. And so we measure the echography of the psoas. Is a very good at the bedside to see if there is a development of local hemorrhage retroperitoneally, which is typical for this kind of patients, just for interest. Now we go to the data on cryobiopsy. You know this study, but just to remind that we found these patterns, you see that we found different patterns from ground glass, white areas, and honeycombing, mainly infiltration of the alveoli, not much edema, but of course these patients died after 25 days, so it's a late phase. And these are very new images. These we collected the data of the anatomopathology, and in red you see the amount of fibrosis, of collagen. So we were able to color the collagen. And you see from the left to the right, the area less injured to the areas more injured. So now we are comparing this quantitative analysis of fibrosis by collagen and the CT scan. And because we have also all the quantitative analysis CT scan. But just to show you that the collagen is increasing dramatically. This is the amount of collagen that we were able to put in evidence that it was not easy, no, in the common, with a very special type of color by our anatomopathologist. So fibrosis, I'm not saying that COVID is fibrosis, but that fibrosis is, if this fibrosis is true, that most of this fibrosis may heal, may improve. So we are doing now CT scanning patients after 3 months, 6 months are much better. So it's a very strange fibrosis. Probably Carmen, probably also Patricia can have more insights on that, because this is not the fibrosis that we know, idiopathic pulmonary fibrosis like that persists. This is a very strange fibrosis. A lot of fibrosis in the early phase, and that this fibrosis disappeared. I'm not an expert on this evolution of fibrosis, but this is very strange. I mean, to me, I studied that when you have fibrosis, you have fibrosis. This is a fibrosis that appears and then disappears. So probably there are some remodeling. I think that remodeling has not been studied. It's very interesting. And these are the data. You see fibrosis in the mid and late dead pattern. And then we found hemolysis, vascular lysis. We found a lot of vascular lysis. I go back to the perfusion. You know some data, but I will show you new data. This is just to remind now what is the venous transmission, which is shunt plus low VAQ areas, and wasted ventilation, which are high VAQ and dead space. So ventilation without perfusion. And then you can reconstruct, you know, the distribution of low VAQ areas and shunt with the black point. So we have no ventilation with perfusion, and on the other side, the wasted ventilation, which is high VAQ, and dead space, which are the region ventilated but not perfused. And this is just to remind that we have, in fact, these two areas on the left. So the venous admixture, which is given by the low VAQ areas, which respond to higher FiO2, and the right shunt, which does not respond to the high FiO2. And on the right, you have the high VAQ and the dead space, which is the waste ventilation. While I showed you that, because we were able to try to measure these kind of things in vivo. These are the phenotypes, more or less, is what we discussed at the beginning months ago. But now we found that mostly of, and I will show you the data now, the non-invasive respiratory support were mainly in the what we call phenotype 1. I mean that, and phenotype 3 was more likely to be intubated. But these phenotypes are not different disease. It's the same evolution of the disease. And why I show that? Because I will show you that our model is that in the phenotype 1, we have mainly low VAQ areas, and in the phenotype 3, we have mainly shunt areas. And in fact, we found that intubated patients were mainly those on the right, so the patients who had mostly what we call phenotype 3, while patients on the phenotype 1 were mainly in non-invasive respiratory support. We use the dual energy blood volume computed tomography, and this is a new technique that is used for pulmonary embolism analysis. And we use exactly this kind of technique, so that the tube is rotating around the chest, and you can see here that the absorption at different energy is different, as especially in the iodine and also calcium, so in the bones. So if you give two energies, the concept is that if you give two energies, you are able to better detect, you see here, the change in density for iodine and the vertebrae, so the bones where we have the calcium, but the calcium is not our interest. So if you give iodine and you measure at two energy rotating the tube, we can put in evidence more clearly the vessels, also very peripheral vessels. So this is our dual energy CT scan. This was the first one that we did, and these are the images. And just to remind you what we found. Our normal lungs, now we measured the weight of the normal lungs in the brain injured patients. So we have now another study in the CT scan in the brain injured patients with and without pneumonia. And so the normal lungs have a weight between 800 grams to 900 grams. Not spontaneously breathing, but mechanically ventilated. The RDS lung is around 1 kilo at 800 grams up to 2.5 kilos. So they have an excess tissue in the RDS as compared to normal of around 1 kilo, 1 kilo 200. In COVID-19 phenotype 1, we found a lung weight of around 1 kilo 100. So it was an excess tissue compared to normal of around 300 grams, 300, 200 grams. So not much. These patients are likely to have non-invasive respiratory support. While patient in phenotype 3, we found an average of around 1 kilo and 600, which is a little bit less than traditional RDS, with an excess tissue of around 800 grams, more or less as a traditional RDS, but 200, 300 grams less. This is the distribution from ventral, middle, and dorsal in those patients with COVID-19 admitted to the ICU. And you see, of course, that in the dorsal lung region, we have more non-aerated tissue and less aerated tissue, while the poorly aerated tissue, so the ground glass, was uniform from ventral to dorsal. So this is a typical distribution that we have also in conventional RDS. So normally aerated more ventral than dorsal, non-aerated more dorsal than ventral, and poorly aerated equally distributed from ventral to dorsal. But what we found is that the distribution of perfusion was completely different. Really, dual CT energy measured the blood volume, but there are studies showing that blood volume is associated with perfusion. So the pulmonary blood volume you see from ventral to dorsal or apical to caudal was higher. So it's non-gravitational gradient. This is very important. In RDS, we found a gravitational gradient. And we found also in some few, now we are doing the study, in brain injured patients. Of course, they can have pneumonia or not, but the distribution of blood volume appears to be gravitational. In COVID, we found non-gravitational. So ventral is higher than dorsal, so anti-gravitational, and there was more perfusion in the apical regions where there was less disease as compared to caudal. So mostly in COVID-19, the perfusion goes towards the more aerated lung areas, while in traditional RDS goes more to the non-aerated lung areas. This is the distribution of gas blood. That's why I showed the VIQ before. It's a sort of VIQ we call gas blood ratio. This study is going to be published soon. And you see that there is an overall distribution, and I would be different, especially in the poorly aerated. Look at the poorly aerated in the invasive ventilation. It's much more poorly aerated area with low VIQ as compared to non-invasive. And then here in the high VIQ also was substantially not anyone, very few in non-invasive. So in invasive ventilation, we have more non-aerated lung tissue, so more shunt, and an increased amount of low VIQ areas. While in the non-invasive, we have an increase in the low VIQ areas, but we have no increase in shunt. And when we look at different hyper-aerated, normally aerated, poorly aerated, and non-aerated areas and non-perfused, this is the overall distribution. But when we look at the non-invasive and invasive, you see the difference. So this is the amount of non-aerated in non-invasive as compared to in non-invasive, invasive and non-invasive. So we have more non-aerated lung tissue in invasive in patients who require invasive mechanical ventilation as compared to patients who were maintained in CPAP by helmet in some way. And you see that part of this non-aerated tissue is non-perfused. So means that part of the shunt is decreased because there is no perfusion in non-aerated tissue. So some thrombosis or collapse of the capillaries might be helpful to reduce the amount of shunt. And then you see a major reduction in normally aerated tissue and an increase in the poorly aerated tissue in invasive with some areas of non-perfusion. This is interesting. This is the distribution of the compartments between invasive and non-invasive. You see, first of all, in blue is the dead space. So the dead space is more or less similar between non-invasive and invasive, but also the gas blood volume higher than 1. But interestingly, you see the gas blood ratio below 1 is less in invasive as compared to non-invasive, but the amount of shunt is much higher in invasive as compared to non-invasive. And this would be even higher if there would be no non-aerated, non-perfused. I think this picture perfectly represents what happens in COVID-19. So in non-invasive, we are mainly low VQ areas and few areas with true shunt. In patients who require invasive mechanical ventilation, we have high area with less VQ, but less than non-invasive, but we are more shunt. In other words, our concept is that non-invasive may be treated with higher FiO2, while when you deteriorate gas exchange, especially oxygenation, you are going to need invasive ventilation. This is also something that we reasoned is the role of respiratory support. You see that in non-invasive respiratory support at the beginning, we can have less transpulmonary pressure, while if we further increase non-invasive respiratory support and the patients start to have reduction in compliance, higher inspiratory effort, higher transpulmonary pressure, it progressively moves towards phenotype 3. What we found was that you see the normally aerated lung tissue was very well correlated with PO2, FiO2. So when PO2, FiO2 is below 100, at that point means that we have only 20% of normally aerated tissue. If the PO2, FiO2 is above 150, we have almost over 50% of normally aerated tissue. If we look at poorly aerated tissue, the correlation is more widespread, but very interesting is in non-aerated tissue. You see that when you have a patient with 100% PO2, FiO2, you have almost 40% non-aerated tissue, while it's less than 20% when it's above 150. So PO2, FiO2 reflect very well the amount of non-aerated tissue and aerated tissue. And overall, we found a relation between PO2 and the overall gas blood mismatch in COVID-19. These are some data that I think may be also of interest. This is what happens when we increase the pleural pressure. And you see that we have different areas. Here, when we increase too much the pleural pressure, first of all, the pleural pressure does not represent the interstitial pressure. So the interstitial pressure here, which is negative, I moved in kilopascal because this is going to be on British Journal, they wanted to have kilopascal. But just to remember here, they see that pleural pressure underestimate the interstitial pressure. So when we see high transpulmonary pressure by pleural pressure, so esophageal pressure, you can imagine that the transcapillary pressure or transalveolar pressure is much higher. This is very important. And you see here that you can reach levels that favor the leakage of fluids from the capillary to the interstitium and to the alveoli. Differently, you see that the coefficient of transmission from the capillaries to the interstitium is much lower when the pleural pressure is much less. So we have to avoid as much as possible a higher transpulmonary pressure, and we can look at this mainly by looking at the respiratory rate, activation of respiratory muscles, and the PCO2 decrease. These are two data on. I would like to be back on the recruitment on PEEP. Of course, this is a study on the limited number of patients, but this is the distribution of recruitment that we found between 8 to 16 centimeters of water. We found that recruitment on average was very poor on average at almost 5 to 8 days from intubation. And even many patients were non-recruiters at all. This is an example of a non-recruiter. You see that there is almost no change between the two levels of PEEP. And this is the highest recruitment that we got in our patients. Overall, we found a poor alveolar recruitment even with higher PEEP level. And we found that the recruitment tissue was around 40 grams, so 3% of the excess tissue, as compared to almost 20% of the excess tissue in traditional RDS. And this was not different in patients with higher or low respiratory system compliance, independently from the time of the CT and from the survivors or non-survivors. These are the other data. Interestingly, we found that the alveolar recruitment was not associated with excess lung weight. This is interesting, in my opinion, means that alveolar recruitment is not due to an increased amount of edema, while in the RDS, alveolar recruitment is associated with excess lung weight. There was no correlation between alveolar recruitment and oxygenation response, likely due to the response in perfusion, and there was no correlation between alveolar recruitment and respiratory compliance at baseline. This is the response in oxygenation at 50% and 100%. And you see that at PEEP 8, you can reach higher level of FiO2, increasing the FiO2, as compared to high level of PEEP at lower level of FiO2. And also we found that most all patients, when we increase PEEP, they decreased respiratory system compliance, so suggesting overinflation. There was no change or no correlation of alveolar recruitment, again, with the delta venous admixture in a subgroup of patients. And probably because the change in venous admixture was due to decreased cardiac output or distribution of regional perfusion. These are very new data that I wanted to share with you. We compared, you see, in 26 and 26 patients, patients who underwent less than 2 days of LMS CPAP, less or equal to 2 days, and more than 2 days. And what we found, this is, you see, the gas volume was lower in those patients who were intubated later. The total lung tissue was higher. And of course, the poorly aerated tissue was higher. All of them are significant. And non-aerated tissue was higher. The PaO2 was lower, and compliance was lower. The excess tissue mass was in the early was 50% versus 60% in the late, so higher excess tissue mass. But when we look at the recruitment, yes, there was some recruitment, but this recruitment was very poor, around 2 to 3% in the early versus late intubation. So the patients intubated late, at least in our group of patients, presented a higher increase in lung tissue, higher increase in the excess tissue mass. But the amount of recruitment was similar in the two groups, suggesting that it's not the edema, but is the progression of this kind of occupation of the alveoli, and sort of fibrosis, more than edema, the main cause of deterioration. And this is the distribution for early intubation. You see here that even in early intubation, the application of PEEP resulted in a higher amount of hyperinflation here. In the late intubation, of course, there was a little bit difference in terms of non-aerated tissue, but was very minor. Prone position, you know that we did a study. This is ongoing to be analyzed. And we found that mainly the effects of prone position was related to the diversion of flow and not to the alveolar recruitment. I know that new data are coming out from another group of looking at the possible explanation of improvement in oxygenation in prone in COVID-19, but our data suggests that this was mainly due to regional perfusion. We used prone position. We used prone position in almost 1/3 of the patients. Many patients improved oxygenation, but also we found that very few, only 1/4 of the patient maintained improvement in oxygenation when supine. This is a study in which we look at the rescue therapy and cerebral systemic oxygenation. You see here the recruitment maneuver, for example, preoperative oxygenation, CO2, and the cerebral CO2. Recruitment maneuver, we found no major improvement in oxygenation, a decrease in cerebral oxygenation, and an increase in the estimation of intracranial pressure by the measurement of nerval sheet, optical nerval sheet. This is a prone position. We found an improvement in oxygenation, but not as much as we observe in traditional RDS. We found an improvement in cerebral perfusion, and we found a smooth but significant increase in the estimation of intracranial pressure. With inhaled nitric oxide, we found a similar, a little bit less, but an improvement in oxygenation as in prone position, associated with an improvement in oxygen cerebral oxygenation, and decrease in intracranial pressure as different from prone position. So I'm not saying that I know as to be directly compared to prone position, but I know at least we got a quite good experience. With echo2R, you see that we found that PO2 decreased with echo2R. And why PO2 decreased? We are looking at that because the pH increased, at least acutely, due to the decrease in CO2. And this is likely altered the hypoxic vasoconstriction. So the suggestion here that when we use echo2R, we have to reduce the mechanical power, I mean, the injury to the lung, ventilator injury, but we have to maintain a certain level of CO2 and pH. Otherwise, if pH decreases too much, what we observe is that there is a loss of vasoconstriction and a decrease in oxygenation. Our idea is that we have happy hypoxia with low lung weight, low recruitability, high compliance, low inspiratory effort due to the low VQRS with high venous admixture, but due to the low VQRS and to the low true shunt. So this is likely to have good oxygenation response to IFR2, and they respond better to non-invasive respiratory support. While what we call unhappy hypoxia is characterized by high lung weight, again, more or less lower recruitability, but low compliance with high inspiratory effort. And in this case, the main mechanism is the high true shunt in the non-aerated lung, of course, an increase in the low VQRS in the poorly aerated RS, and also a progressive increase in the high VQRS, mainly in the poorly aerated tissue in the wasted ventilation. So there is a poor oxygenation response to high FL2 or to very high pressure with a high ventilation ratio, and these patients are likely to require intubation. This is our how we interpret this data. This was our protocol for non-invasive respiratory support. So we look at oxygenation. We tested for 15 liters per minute with reservoir. And in case we had lower saturation, we use HFNOT or CPAP, but for, if possible, for 6 to 12 hours. And then according to the evolution in terms of oxygenation rescue rate, we decided to intubate. Of course, accessory muscle activity, reduced PCO2, and eventually lung imaging might be helpful. I don't know if we were able to avoid or not, but 60% of patients treated in this way were not intubated. We don't know if this was avoided or not because they were anyway treated. We believe that we have not to delay too much intubation in these patients. So at the beginning, high flow oxygen nasal therapy when we are in the happy hypoxia, then eventually some non-invasive positive ventilation, and but in case of deterioration, intubation is mandatory. I would like to share with you, just to conclude here, some recent data on physiotherapy that we just published 2 days ago. This is a study on 65 patients who underwent physiotherapy with some protocolized maneuver during pressure support. You can see this maneuver that can be under discussion. That's what our physiotherapists did, or during spontaneous breathing. Are different maneuvers, and we perform, of course, bed elevation, and we perform everyday physiotherapy in the morning and in the afternoon. And we perform a very simple study. So before physiotherapy, then we did physiotherapy. We look immediately after physiotherapy and after 6 hours. This is the overall population of patients. So they started from 180 because these are patients in assisted ventilation and some patients here in spontaneous breathing. After physiotherapy, as I show you, look at that, the PO2 improved dramatically, very much improvement in PO2, which was maintained at 6 hours. So very interesting data, showing that physiotherapy was very effective to improve oxygenation. This is, of course, during assisted breathing. And this is the population of patients in which we were able to perform lung ultrasound, which was the same. Then we performed the lung ultrasound. We did not find major change. Some patients decreased, other patients did not change too much. What we found was that the variation in lung ultrasound was higher in patients who had more gas. So patients who had more gas, they had a better response in terms of variation in lung ultrasound as compared to patients with less gas. But there was no correlation in terms of variation of lung ultrasound and response in oxygenation. There was no hemodynamic effects between patients. So we concluded that chest respiratory physiotherapy improved oxygenation in this small study with severe COVID-19 ICU patient during assisted ventilation or spontaneous breathing. That was could be very safely applied in this, and of course should be carefully organized, minimizing possible risk of exposure. And lung ultrasound might be helpful to look at the changes in aeration during the maneuver. So I think the respiratory physiotherapy should be combined with lung ultrasound. So these are the conclusion here. This is our view, but of course it's under discussion. We found that it was more likely to be a sort of primary LDS with pneumovascular lysis, less edema, at least from our data. Coagulation, of course, is very important. And fibrosis is very interesting because I showed you that even after death at 25 days, there was increasing fibrosis, but we know that at least several patients, when we will look at 3 or 6 months, they had reduced fibrosis. We use corticosteroids. We use also methylprednisolone, I can tell you, at higher dosage. So we don't use 30, but 60, 70 milligrams. And then we taper off after 1 week. We did not use any more tolicizumab. You know that some studies, very contradictory data. I did not have time to show you, but we did 2 studies showing that tolicizumab plus corticosteroids was associated with 10 times more infections, so we don't like to associate both. We don't use tolicizumab anymore. We don't use any more remdesivir for ICU. It's used sometimes, but after, when the patient is not so severe. We use antibodies, monoclonal antibodies, but not in the ICU, just if in the first week when we develop some symptoms. So at the end, in the ICU, corticosteroids. Anticoagulants, I show you that our experience was that when the dimer starts to increase, we for more than, I wrote 1,500, I can say 3,000. We started to have therapeutic enoxaparin at 6,000, 4,000 times 2, 6,000 times 2, or even more with heparin at 25,000. Our data, not randomized, suggests that was effective to improve survival and ventilator support. I don't want to be back here. I showed you hypoxia, and hypoxia, in our opinion, clearly explained by the VAQ. Hypoxia, low VAQ areas, and hypoxia shunt, to be very simple. So these are our management. So we started in phenotype 1, non-invasive respiratory support, but early intubation. If there was within the first hours, 6, even we can say 12 hours, with increasing respiratory rate, deterioration in saturation, PC2 accessory muscles activity. In phenotype 3 of phenotype 1, we did early intubation. Of course, this is according to the organization. Protective ventilation, as you know, as we do also in traditional RDS. However, the PEEP range was lower than compared to traditional RDS. This was at least our experience, and we use more higher FiO2 as compared to higher PEEP level. We use rescue maneuver only as a rescue. I show you our study on the interaction with the brain, and we try to minimize the oxygenation target by giving some more hemoglobin to, in case it was needed to optimize DO2. We used in some patients anitic oxide. We use prone position. We use echo 2R, but in order to control the PAs and pH, PCO2 and pH, especially when protective ventilation was not possible. Now we have a collection of around 30 patients in echo 2R, while we had a very bad experience with ECMO. And I think that both of you are happy to see that we loved it. We were very concentrated on physiotherapy. We have to thank our physiotherapist, and especially Dr. Kaifa, who was one of the leaders in our ICU. And this was just the second study we did on physiotherapy. We found very interesting results really on the, I can say, medical effects, clinical effects on physiotherapy. Not only physiotherapy for respiratory muscles and like that, but also for chest physiotherapy was very effective, and we believe that is mandatory in these patients. So I try to give you a sort of review of what we did and what's the points actually for COVID-19 in our hospital at least.
Okay, Paolo, very nice presentation. Thank you.
So I try to what we did really doing in practice. Of course, is open for discussion.
Okay. Now Carmen will speak. Thank you, Carmen, once more. Great pleasure. I think that your microphone is stopped.
Now it's okay?
Now it's okay.
Thank you, Sergio. Thank you, Bruno, for the invitation. And thank you, Paolo, for this interesting information about COVID-19. And I will show you some Our experience with COVID in the University of São Paulo and the Albert Einstein Hospital in these 10 months, because in the first 2 months I was intubated and mechanical ventilator. So in these last 10 months. So COVID-19 is caused by the SARS-CoV-2 virus. It's a RNA virus, and it starts in Wuhan, China, in December 2019. And after some months, they spread around the world. And in October 2000, is a real pandemic with 3.2 global mortality. And today we have 162 million cases with 3,003,000 deaths because of COVID-19. But the vaccine is increasing around the world, and we hope it can control the COVID-19 pandemic. In Brazil, we have 50 million cases and 434,000 deaths until today. And the global mortality is 2.07% today. It's interesting that in China, there is a very little COVID-19. We don't know why, but we have to investigate that. And in the US, we have a lot of COVID-19 spread. In Brazil, only in the littoral, but in the US, we have a lot of COVID-19. But COVID-19, we are going to talk about the lung and the COVID-19 and the mechanical ventilation. Around 15 to 25%, 20% of the patients had a lung, a commitment. Most of them with a viral pneumonia. It's the ground grass spread in the two lungs bilateral. Some patients develop ARDS. Some patients have pulmonary embolism. Some patients evolve with organizing pneumonia. It's very important to recognize it because this organizing pneumonia is responsive to corticosteroid. So it's very important to recognize and treat with high dose of corticosteroid because this patient respond well. As Paolo Pelosi say, after 9-10 days of mechanical ventilation, we are seeing a lot of secondary infections, bacterial, fungus, and cytomegaloviruses. And little patients develop pulmonary fibrosis. We are looking these patients over time, and these patients after mechanical ventilation, usually if you do a lot of physiotherapy and rehabilitation, they improve it along the time, and we can take off the oxygen, and they improve a lot the pulmonary function. We do a lot of training of the respiratory muscles and expansive maneuvers with some apparatus that you can improve your vital capacity during the rehabilitation program. The COVID-19, these patients that need the oxygen, we have to do a safe oxygen therapy. You have to use devices that are close, to minimize the aerosolization of the air with the viral particles. So you can use this kind of inhalation mask with oxygen. It's a closed system, and you can have a very high FiO2s. Or you can use, as Paul say, high flow oxygen, and you can put a surgical mask around the face of the patient, or you can use in negative pressure rooms, and the healthcare providers have to use safe equipment to avoid the contamination with SARS-CoV-2 virus. During high flow oxygen, we have to monitor the patient. Now we are using a lot the HOX index. If it's higher than 5, you can be, the patient is well, is lower than 3. Usually you have to take care and monitor these patients every 2-3 hours to follow the patients and to intubate if necessary, or keep the patient with high flow, alternate with no invasive and proactive prone. As Paulo say, we use it in Brazil, in São Paulo, Brazil, the same as as Paulo used in Genoa. So this is the patient. So the non-invasive support, we are using all these things, trying to oxygenate and ventilate the COVID-19 patient to avoid intubation and invasive mechanical ventilation. So the patient stay in the high flow. We have a protocol in Einstein. The patient stay in the high flow. Then after 3 hours, we put the patients in the no-invasive ventilation to ventilate and try the patient to rest a little bit, the muscles. And we alternate this with active prone position, trying to improve oxygenation and decrease the respiratory rate. And we have a lot of cases. At the end, I will show the Albert Einstein experience. We have 1,000 patients in this last year with COVID-19, and you show the Einstein experience with this type of ventilatory support. This is the patient. All the patients. The COVID-19 loves the obese patients, hypertension, diabetic, and obese patients, and they lose a lot of weight during the hospital stay. And but if you give a protective support, corticosteroids, anticoagulants, and different from Paulo's experience, we are using tocilizumab, trying to avoid intubation if the patient needs high flow or no invasive ventilation. The procalcitonin is very low. PCR, reactive C protein, is higher than 75, and interleukin 6 higher than 50. We give these patients at the beginning, trying to avoid intubation. You are having a very good experience with that. This is a lot of debate about that. We avoiding the intubated patient, but if they started the ventilatory support and they are worsening using corticosteroids, the dexamethasone or prednisolone 6 milligram a day or 40 milligrams a day, we associated tocilizumab. We are starting a protocol, and the first results are good. This is another case just to discuss and see. A old woman with SARS-CoV-2. We use high flow associated with no-invasive ventilation, and we have lots of patients that when you put in no-invasive ventilation, this 8 of EPAP and 8 IPAP and EPAP, the FiO2 falls a lot, decrease, for example, for 70 to 40, and we do this alternate, and this patient improved the clinic, had a clinical improvement, radiological improvement, and she can use nasal oxygen 1 liter per minute. The other thing we use it is during the ventilatory support is no invasive ventilation. We use a mask with a filter. If you use a ICU ventilator or in no invasive ventilation or in pressure support ventilation, and you have to take care with the healthcare provider, the physician, physiotherapist, the nurse, and you have to put the face shield, the glasses, the avental, I don't know the name, and the cover, and to take care with the virus contamination. And the non-invasive ventilation, we have a lot of problems here in Brazil, but it's very easy to use in a safe way if you use a mask, a filter between the mask, you have to use a no ventilate mask. The mask, the filter, and the exhale valve has to be after the filter. So if you use a no ventilated mask, the filter and the exhalation valve after the filter, it's secure for the healthcare providers, and you can use a no invasive ventilation, or you can use the ICU ventilator with the filter at the end of the no ventilate mask with double circuit. And if you use a unique one circuit, you can put the filter between the mask and the exhalation valve. In our hospitals, we have a Brazilian negative pressure that helps to improve the ambient from the aerosolized particles of the viral particles, or you have to use all these safe procedures to take care of the COVID patients. We use in Einstein and in the University Hospital the NIV in the prone position. It's the same thing you do. Usually at night we ask the patient to sleep in prone, so the patient can spend his night or her night in the prone position, and during the day the patient started the supine. The patient can do physiotherapy and all the things they have to do during the day, and during the night we ask them to sleep in the prone position. This is a Italian paper that suggested is a pilot one that showed that during prone position the patient can improve the saturation and decrease the respiratory rate. So we try to alternate the position to avoid intubation. This is a patient with COVID-19 that we did this. We alternate high flow with NIV and prone, and at the beginning, I was not sure if the patient will tolerate, but if the patient are comfortable with a low respiratory rate and a low respiratory drive, we can keep them in high flow and NIV and prone, and the patients have an improvement. You can avoid intubation and mechanical ventilation. If the patient are not comfortable doing a very high respiratory effort or has a very high respiratory drive, we intubate and do invasive mechanical ventilation. Here in the university, not in Einstein, but in University of São Paulo, we started, after the Italian papers, we started to use the helmet with high flow and CPAP. We put the patient in the CPAP with high flow, and you are having a good experience with that. And we started in these last 6 months, and we are seeing a good results at the clinical practice. This is the paper of the group of Massimo Antonelli from Domenico Greco that they published in the JAMA in March. They randomized the patients to helmet and no invasive helmet and high flow nasal oxygen. And this is the helmet with PEEP of 10, 12, pressure support of 10, 12. And the primary outcome is respiratory free days. Support free days were not different between the groups because the helmet was considered a non-invasive support, but the group that used the helmet, they have a much less rate of intubation. So the helmet avoided the intubation. The odds ratio was 0.4 to 1, and the invasive ventilation free days was also significant. The helmet group had a higher invasive ventilation free days. So it's an interesting alternative to these patients. You can use the helmet with pressure support and PEEP, trying to avoid intubation and invasive mechanical ventilation. And when you have to intubate the COVID patient, if the COVID patient with the no-invasive support, high flow and no-invasive ventilation, have a decrease of consciousness, that they do not protect their airways, have a desaturation with 100% of oxygen, and in the Einstein 800 we intubated the patient, have a very high respiratory rate or worsening, a radiological worsening. We intubate and ventilate, invasively ventilated this patient. This I will show a typical tomography, thoracic tomography of COVID-19 patient. They have a ground glass, bilateral ground glass, and these patients, these more severe patients, usually have more infiltration of the lungs at the bottom of the lungs. So the intubation, they have to do a safe procedure. If you have a laryngoscope, it's best to use a laryngoscope. The healthcare providers must be protected with the right clothes. And after the intubation, you have to do a protective ventilation. So, oh my God, it's in Portuguese. You have to use a low tidal volume, less than 6 ml per kilo of predicted body weight, driving pressure less than 15 centimeters of water. We started with a PEEP of 8 and 10, and we collect arterial gasometry, and the FI to have a peripheral saturation of 93, between 19 and 96, and we saw the PO2 FiO2 ratio. If it's less than 150, we prone the patient, and if it's more, we try to do a mini titulation of the PEEP with the impedance tomography. Besides the ventilatory support, we try to do negative fluid balance or zero negative fluid balance, adequate sedation, coradization if necessary, corticosteroid anticoagulation, treat secondary infection. And here in Brazil, it's around 5% of COVID patients that need mechanical ventilation, and the patients that are inside the hospital, more or less 40%. And the mortality around Brazil varies from 20 to 80%. In the north of Brazil, we have 80% of mortality in the intubated and mechanical ventilated patients. Here is the international experience, né? Italy, US, Amsterdam with COVID-19 that was published in the Lancet Respiratory Medicine. And we see here a very high rate of invasive mechanical ventilation. Some countries use it as Italy, New York use no invasive, and high flow in US too. The PO2 FiO2 ratio is around 150. The compliance of these patients, in the beginning, they thought that the compliance is higher than the traditional AERDS, but nowadays we see that the patients that are mechanical ventilated have a low compliance, here 26, for example. The PEEP, they use it around 10 to 15, very high FiO2s in all the countries. Prone position around 30-40%. In Iceland, we are using 40% of prone position. And ECMO in some countries, in New York and Italy and Boston, around 1 to 5%, where we are using ECMO in Iceland and in the University of São Paulo. So here is you use a lot of, in University of São Paulo and Iceland, you use impedance tomography to titrate the mechanical ventilation. We see the distribution of the air and trying to keep the driving pressure less than 15. Here I did a resume of all the impedance can show us in the supine and the prone position. We can see the ventilation, the distribution of the ventilation. We can titrate PEEP levels with the PEEP titration tool. We can see the perfusion with the injection of 10% saline. And if the patient is with assisted ventilation, we can monitor the asynchronous. So here is the titration of the PEEP, the asynchrony tool, and the perfusion if necessary. We are using a lot of prone position, more than before, because the COVID-19 patient, they have a very fragile lung, so we use PP around 10 to 15, and some patients that are not evoluting well, we go to the tomography or use the impedance to recruit the lungs and titrate the PEEP. Some patients we need 18 of PEEP, the more severe ones, but we recruit with the impedance or the chest tomography, and you use prone for 16 to 24 hours, according to the shift or according to the severity of the patient. Here is one of our COVID patients that had this condensation at the right. He had PO2 FiO2 rate of 120, and the physiotherapy team wants to recruit this lung at the bedside, and you see after the recruitment maneuver, the ventilation, the distribution of ventilation between the right and the left lung improved. The distribution between the superior and inferior was the same. And here we can see that the ventilation of the condensed areas improved, the distribution was better, and for our surprise, the PO2 FiO2 ratio increased from 120 to 400. So it's important to understand what is happening with the lung, this heterogeneous lung, and gently trying to adjust the ventilation, because impedance can provide you a tool that you can see the ventilation. Here the ventilation improved in the right lung, and the patient improved a lot. COVID-19 is not only the lung, as Professor Paulo said us. We have patients with stroke, confusion, a lot of delirium, myocarditis, a lot of arrhythmias. We had two pericardial tamponates that we have to drainage the patient in the urgent, the drainage. A lot of patients in shock with noradrenaline, a lot of pulmonary involvements, some patients with hypernatremia, renal failure, and some patients that need nitric oxide and ECMO. And we monitor the patients with protein, interleukin-6, the dimer, ferritin, procalcitonin, and cultures to follow the patients until they improve a lot. We are seeing a lot of tetraparesia. I don't know if it's tetraparesia. It's a motor. The patient are tetraparetic, not move well. It's very difficult, and we are doing a lot of rehabilitation. Now, this is the patient that was in the mechanical ventilator, improved. And here, the Professor Paulo also discussed, but I want to show some monitoring that we are doing, because these COVID patients are very difficult to ventilate it in the assisted mode. They have a very high ventilatory drive, very high inspiratory force, and sometimes we have to do a lot of give them a lot of sedation. Sometimes we have to paralyze the patient because the patient has a dysfunctional drive, and some patients are very difficult to follow in the assisted mode. So we monitor the P.1, trying to monitor, and the patient stay with P.1 less than 4 centimeters of water, and we try to monitor the asynchronous, the double trigger, and the lost effort. So you have to try. And the P.1, this patient was tetraparetic with very difficult to ventilate, and the P.1 is minus 11 centimeters of water, and this is the patient in pressure support, very asynchrony, very difficult to ventilate. And then I will show this patient. He stayed 6 months at the ICU, and finally we managed. Very difficult to manage, but then they went home after 6 months of COVID-19. So it's very important to measure P.1 and the expiratory occlusion. This is relatively new. We learned with the group of Gollinger, Laurent Brochard, Arthur Slutsky, and the Italians group to Giacomo Bellani também taught us how to monitor these patients a little bit better than before. During pressure support, we can do a inspiratory pause, and if the plateau pressure was more than the pressure support, the patient is doing a high inspiratory effort, and we do the expiratory occlusion to see the respiratory muscles pressure. This is the we call here in Brazil occlusion pressure, POC. This is you do a respiratory occlusion, and you see how you measure the negative pressure the patient does during the pressure support. Então here is the expiratory occlusion pressure, and the paper show that if you compare to the esophageal balloon, the predicted muscles pressure is 3/4 of the occlusion pressure, and if the predicted PMUS is less than 13, 15, it's okay. If it's more, the patient is doing a very high effort, and you have to trying to correct the assisted ventilation with maneuvers. You can change the expiratory cycling off, or the slope, the inspiratory slope. Try to adjust it, and if not, you have to increase the sedation, or try take the sedation according to the inspiratory effort of the patient. You can measure também the transpulmonary pressure. It's the effort associated with the pressure support. If the patient do well during the mechanical ventilation, the patient that easy go patient, you do a spontaneous breath test, SBT, with 5-7 of pressure support, 5 to 10 of PEEP, and you can estimate to the non-invasive high flow or to the oxygen mask. And here in Brazil, we use a lot of non-invasive in high flow to avoid reintubation. We keep these patients 24 hours in non-invasive or high flow before the patient goes to the oxygen, trying to avoid the reintubation. The weaning of these COVID patients are not easy. They have a very high P.1, a lot of muscles weakness, a lot of asynchronies, but you can manage all these things. You have to stay with the physicians, with the respiratory physiotherapists at bedside, trying to understand what are happening with the patients, and trying to adjusting the mechanical ventilation to that patient, and then we can intubate to the non-invasive and do the rehabilitation to the patient go back home and go back to the work. The team of the respiratory physiotherapists do a very good work with us. The rehabilitation of the COVID-19 patient is not easy. They have a lot of work. These patients are very asynchrony, a lot of respiratory muscles weakness. And here we have a video to show you this. They have a lot of muscles weakness. In the ultrasound, we can see that these muscles are very weak, and they have a lot of asynchrony. and the physiotherapists have a lot of work to do with these patients. If the patients didn't go well in the invasive mechanical ventilation, uh, in in the Einstein and in the University of São Paulo, we are doing ECMO. We are reference centers of ECMO. A lot of work because it's not easy to do ECMO in this patient, but we are reference centers, so you have to do. No option if you want to save the lives of the more severe patients. So if the patient not cannot keep a protective ventilation with the mechanical ventilation, we need more than 50 centimeters of water or 20 centimeters of water to ventilate the patient. The patient need FiO2 more than 100. The compliance is very low, less than 20, and the PCO2 very high with a low pH. We started the VV ECMO, venous ECMO, so we can increase the oxygen and decrease PCO2 through the ECMO membrane and keep a protective ventilation, trying to save the life of these COVID patients. If the now in Brazil we are having COVID in more younger patients, 40, 50 years old, different from before. So we are having a lot of ECMOs. Usually you have 2 ECMOs in the University of São Paulo every day and 4 ECMOs in Albert Einstein every day. So this is the patient in ECMO. So usually we drainage the blood from the femoral vein and return it in the right jugular vein, and the lung stay with a low respiratory rate, 10 to 15 of PEEP, and 10 of driving 5 to 10 of driving pressure, while the patient are in ECMO, trying to rest the lung and give time to the patient to recover their lung function. Sometimes we are using a lot of pronin ECMO. In the COVID patients, some patients that the compliance are very low, it's very difficult to increase the PEEP more than 15. So we are using prone position during ECMO, and some patients are improving with prone position in ECMO too. This is the experience of the ELSO. We follow the ELSO, the International Society of ECMO. This is their experience with 1,035 patients with COVID-19 that received the ECMO support, and they reported a mortality ratio of 38% in 19 days. In Einstein, we have in a 6% mortality. We are having a 40% survival of these more severe patients, but they are very complicated patients that arrived to the hospital in a very severe with a lot of infection. It's very difficult to manage all these things at the bedside, but we are trying to do our best to save these lives. This is the cumulative mortality of ELSO, that they reported 38% of mortality in COVID-19 patients at 90 days. And this, I will show you some patients, the very difficult patients. This is a very severe COVID-19 patient. This patient is staying in the hospital 6 months. They have a lot of motor difficulties to walk. The physiotherapists do a very good work to rehabilitate these patients. They have a lot of complications, infections, and subnutrition, difficult to give a good nutrition to them. And after 6 months, he can left the hospital. Opa. This other one is a very obese patient with 106. Goes to me. With the tracheostomy, he's very obese and loves to eat during the tracheostomy. Opa. So he left the hospital with the same weight because he loves to eat a lot, even during the tracheostomy. But 3 months in the hospital because of COVID-19. The Are you hearing me? The connection is okay?
I hear you.
Yes,
Okay.
Carmen.
No, because it stopped the connection.
Carmen is frozen, yes.
Yes, it's frozen.
And hi, this is the Einstein experience with COVID-19, that we are finishing to join the data of Einstein. In the last year, we have 1,296 patients with COVID-19 in the hospital. The median age was 66 years old. The entire hospital survival was 86%. In the mechanical ventilation, 31%. And in the ECMO, 40%. During the ICU, we have 56% in NIV. 11 por... Alô? Alô? Olá? 11% received renal replacement therapy and 5% received ECMO. We calculate the independent predictor of hospital mortality. Age was an independent predictor of mortality. SOF score, or Charlson Comorbidity Index. Use of mechanical ventilation, the odds ratio was 4.45. Use of renal replacement therapy, 342. And renal replacement therapy and ECMO 8.18 as an independent predictor of mortality. So mechanical ventilation 4, the odds ratio, and ECMO 80. The use of renal replacement therapy at 3.4. So in conclusion, COVID has a variable clinical presentation, and this pandemic, hypoxemic respiratory failure is the most serious complication requiring high flow oxygen therapy and no invasive ventilation and invasive mechanical ventilation with high mortality. ECMO can be indicated in cases of refractory hypoxemia or in cases that you cannot maintain protective mechanical ventilation. They also report a mortality of 38%, but we are our mortality are around 60%.
Thank you, Carmen. Very nice presentation. Very nice, very nice. Thank you. Are you hear me?
Yes.
Okay, Bruno. Carmen, finish? Carmen? Can I start, Bruno?
Yes, Sergio. Let's go.
Carmen, acabou?
Ela caiu.
Caiu a internet dela?
É, mas sem problema, pode começar. E eu admito ela na hora que ela entrar. Só para, enquanto o Sérgio está colocando a apresentação, as perguntas estão ótimas. Obrigado, Paolo Pelosi, por estar respondendo todas. Tá muito bacana, Sérgio. Tá? Pode apresentar, por favor.
Just a moment.
Carmen voltou.
So that no. So Sergio, it's our experience here in São Paulo. You can start your lecture now.
Just a moment, please.
One of the people from the audience asked if you use ECMO without mechanical ventilation in COVID-19. We didn't use ECMO without mechanical ventilation in COVID-19 in Brazil. Maybe around the world some group can have this experience. I don't know if Paulo know.
I also noticed this question. No, we also use the mechanical ventilation, and that's why I think that the data that you also presented, by the international group of ELSO, I think should be interpreted very cautiously, because they included patients very likely they included patients even after 3 days of mechanical ventilation. So, of course, they got a mortality of 40 days, of 40%, yes, but they included very likely patients that we even never would have included or treated in the conventional way. So I think that the mortality of ECMO is very difficult to be interpreted, because it depends on how the patients were selected. If you increase, if you enlarge the type of patients that are under ECMO, of course, you reduce the mortality. If you treat the most severe patients, or after days of mechanical ventilation that you receive from other centers like that, mortality is higher. So interpretation of mortality with ECMO is very difficult. But I agree with Carmen, we also will never do that with very risky, very risky.
Okay. Okay, Bruno?
Okay, Sergio, let's go.
Okay, sorry about that.
No problem.
So thank you one more time, Bruno, Paolo, and Carmen. So in the beginning of the pandemic, several definitions were made about the COVID, but nowadays, multiple organ dysfunction, as Paolo told us, is the more appropriate definition for COVID. So we know that COVID is not only a pulmonary disease, so we have a dysfunction of heart, lung, brain, so it's a multiple organ dysfunction. So it's important to emphasize that COVID is not only a pulmonary disease, as Paolo told us, as Carmen told us before. High flow nasal cannula and non-invasive ventilation are used a lot nowadays. So in the beginning of the pandemic, the message was avoid non-invasive ventilation because the risk of environment contamination. But nowadays we are using a lot non-invasive ventilation and high flow nasal cannula. Carmen shows this study, and in this study, intubation was lower in helmet group in comparison to high flow nasal cannula, 30% versus 51%. And the number of days free of invasive mechanical ventilation was higher in helmet group again, and 28 versus 25%. Mortality did not differ in this study. So we can use the ROX index, as Carmen told us, and as higher the result, better will be the prognosis of these patients. In this case, 4.48 is a better result, so we can continue the therapy with high flow nasal cannula in this situation. In April of last year, this study published by these authors in New York City was really scared because the mortality on mechanical ventilation was about 80%. So New York, United States of America, presented 80% of mortality, was really scared, but we are trying to improve these results. So at the beginning, high mortality on mechanical ventilation. Nowadays, the result is so different in comparison to the past. Another question is compliance of the respiratory system predominantly normal? So in the beginning, Gattinoni told us that 20 to 30% of the COVID patients admitted in the ICU presented a compliance below than 40. So I cannot observe the same results, and I try to make a record of the compliance of our patients. In the beginning, so we have to ask this question: was near normal compliance prevalent? I don't think so. So Paolo published this nice study and divided in phenotype 1, 2, 3. The phenotype 1 presents a good or normal compliance, and the phenotype 3 is like a ARDS pattern. So in this situation, we have, of course, low compliance, and here good compliance. So I observed a lot of studies, a lot of papers talking about the compliance. And this study in France and Belgium, the authors observed a compliance around 37, 38 in the first day, and 14 days later, about 31. So the compliance is not high in this study and in several studies, as I will show you. In this study in Netherlands, the compliance was about 32, so low compliance again. In this larger study in Spanish, more than 700 patients, the compliance was low to about 35, 29. They used a lot of recruitment maneuvers, a lot of prone position. Recruitment maneuvers was used in 80% of the patients with severe ARDS. The mortality, thank God, was low, about 32%, or about, and an ICU length of stay about 19 days. So phenotype 2 and phenotype 3 are frequent. Compliance generally is lower, and phenotype 1 is higher, and the mortality decreased with the last year in comparison to nowadays. This nice study of my friends in Brazil performed on Redditor hospitals in São Luís, where my friend Bruno works, evaluated more than 3,000 patients in 126 ICU from 42 hospitals. And they evaluated a period for 8 months, I think, 8 months. And at the beginning, they observed that the age was higher than now. So patients with 40 years old was about 90%, but nowadays is about 25%. 25%? Yes, it is 25%. They use more non-invasive mechanical ventilation. The beginning about 8.3%, and nowadays 25%. The mortality decreased 17%, and nowadays 9.6%. And the mortality only in mechanical ventilation about 57%. So the mortality decreased in non-invasive ventilation. They are using more non-invasive ventilation and high-flow nasal cannula than the beginning. In the beginning, we are so afraid of the environment contamination, but now we relax according to this fact. And there are more younger patients at the moment. I remember that a few weeks ago or last week, I came into my ICU and I observed that there was only one patient older than me. And this patient was only 58 years old. And I really don't know what to think, because for the first time in my life, after 30 years working in an ICU, I observed something like that. Only one patient older than me in an ICU place. There's another kind of ICU. So ICU for young adults or post-teenager ICU. I don't know what to think. It's really strange. The Surviving Sepsis campaign published last year the guidelines for COVID, and a few months ago they published the first update of this guideline, and they divided in severe and critical COVID, and made several recommendations. There are a lot of recommendations, of course. I will talk only about some recommendations. So they don't recommend the awake prone position, different from other guidelines. They recommend high flow nasal cannula and non-invasive ventilation, but with weak recommendation. High flow nasal cannula and non-invasive ventilation can be done, but with caution. If the patient deteriorates its work of breathing, of course, the patient should be intubated immediately. Lung protective ventilation should be done with strong recommendation. So the tidal volume between 4 to 8, I prefer around 6 milliliter per ideal body weight. should be done, and plateau pressure in less than 30, as we know, is a strong recommendation too. High PEEP levels, strong recommendation too, and prone position was really strange, weak recommendation. So prone position should be done and is recommended for almost all of the guidelines that are observed nowadays. So prone position between 12 to 16 hours or maybe to 24 hours is recommended. Nitric oxide can be used in case of patients that present perfusion problems. So we can use nitric oxide in order to improve lung perfusion. It's an example of nitric oxide. Recruitment maneuvers is polemic. I like a lot of recruitment maneuvers in ARDS patients, but in COVID we have to do in patients with severe ARDS associated and more in patients with compliance decreased about maybe less than 20. It's not a good indication only in severe ARDS patients. So we have to do recruitment maneuvers with caution because some patients present pneumothorax or pneumomediation. But these parameters, peak pressure, PEEP pressure, are not necessarily associated to pneumothorax. So we can use recruitment maneuvers, but with caution, of course. And this consensus, Paolo already showed us. I will not repeat, but in this consensus, they recommended prone position in awake patients, non-invasive ventilation, high flow nasal cannula. So invasive ventilation with prone position, and of course, protective ventilation, and once more, recruitment maneuver, but with caution, of course. And we have to select the appropriate patient to recruitment maneuver. And the winning, we have to prefer pressure support ventilation than PPs, of course, in order to avoid environment contamination. But nowadays we relax regarding this purpose, of course. Mobilization, as I am a physiotherapy, I will defend this hypothesis that early mobilization is beneficial for patients even during the respiratory support. This is a nice study performed by our friend Gustavo Janot and Carmen. So in the past, it was 9 years ago, they performed a recruitment maneuver up to 45 centimeters of water of PEEP, but without electrical impedance tomography, and in COVID patients, maybe a little recruitment up to 25 or something like that is enough in patients with COVID. It's not a full recruitment maneuver that we recommend for these kind of patients. Carmen and me, we wrote this letter for JAMA 3 years ago, I think. So we pointed the problems of the ART study that told us that recruitment maneuver should not be done. So I disagree, Carmen too, of course. So we have to keep in mind that we can do the recruitment maneuvers, but of course with caution, and it's not for all patients with ARDS. So we can use recruitment maneuver, but a lot of caution regarding patients with COVID. So for ARDS patients, we have advantage in use prone position, but of course that we have another attraction in COVID patients, that is the distribution of the lung perfusion. But in ARDS patients, we can observe less collapse of the dorsal lung and less overdistension on the ventral lung when we prone the patient. But the distribution of the lung perfusion is another advantage of prone position in this patient with COVID. So I like to use larger supports in order to leave the abdominal free. So it's important to allow the diaphragm, the passive mobilization of diaphragm. No contact with tube according to the bed, so we have to leave the tube free. And then study, a multi-center study, we observed that the authors told us that only about 1% of the patients develop pneumothorax. This can occur with or without lung disease or with or without mechanical ventilation. And two-thirds of the patients survive, but age higher than 70 and acidosis were associated with poor prognosis in this situation. In another study, a systematic review about pneumothorax, the risk factors for COVID related to pneumothorax was pre-existent lung disease, smokers in less than 34%. The pneumothorax can occur even or without mechanical ventilation, as I told you before. Plateau pressure in less than 30, PEEP in 10, and tidal volume in 5.4. Protective ventilation, but does not alter the results of pneumothorax. So pneumothorax or pneumomediastinum can occur even in protective ventilation or without protective ventilation, even in awake patients or intubated patients. Respiratory rate in 24 more was more associated to pneumothorax in this systematic review. So we can increase respiratory rate up to 35 refs per minute according to Brazilian guidelines or other guidelines. 35 is the limit for the great majority of guidelines, but the high respiratory rate is more associated to the pneumothorax than the plateau pressure and PEEP or even recruitment maneuver for this systematic review. So tachypnea on admission and PEEP intrinsic, more pneumothorax too. Titrating the best PEEP, we have to observe the alveolar collapse between 0 to 5% on electrical impedance tomography, if available, of course. If not available, we have to observe the lower driving pressure or the higher compliance. It's the same thing. Or we have to use the lower PEEP table, but I like a lot lower driving pressure at the bedside because it's more associated to lung protective ventilation. We have to observe that the PEEP table is so strange in some situations when we observe a patient with normal compliance and bad oxygenation as a consequence of lung perfusion. So in this situation, if we use a PEEP of 20, 24, we have bad results. So PEEP table is not appropriate in my opinion, at least in my opinion, in situations of pulmonary embolism, compliance, normal compliance, arterial hypertension, or pulmonary hypertension. So if we use in the first moment PEEP table, we have to prefer lower PEEP table, lower PEEP FiO2 table. It's practical and quick, but I prefer to use the lower driving pressure or the highest compliance. But of course, if impedance is available, we can use impedance and observe the collapse and the hyperdistension. In this situation, the best PEEP for this patient is around 14 or around 12 centimeters of water. Here we can observe a collapse of 2% and 4%, but 10 centimeters of water of PEEP is a low PEEP for this patient. We can observe the collapses in this situation, and here we can observe 8% of collapse. So We can choose 14 or 12 centimeters of water of PEEP for these patients. Monitoring the respiratory drive of these patients is so important too, because we have a lot of patients with silent hypoxemia, but in ICU, we observed more patients with unhappy hypoxemia, as Paolo told us. So we can observe, we can monitoring the P.1. In this situation is almost normal P.1. The normal values ranges between 0.5 to 1.5, but in mechanical ventilation, and up to 3.5 is accepted as a normal, not a normal drive, but a little elevated drive is accepted in patients with mechanical ventilation. So 1.7 is really normal. We can evaluate the work of breathing between 0.3 to 0.7 or almost 1. 1 is normal. Not 0.7, 1 is normal. We can observe the electrical activity of diaphragm, but only in NAVA. So we can observe that the normal electrical activity of diaphragm is 2 to 10, and some studies show us that more than 26 is related to a possible winning failure. As Carmen told us, we can observe the occlusion pressure is different for P.1, and we can observe the transpulmonary driving pressure. So it is so interesting. In some ventilators, we can observe this pressure. So the normal PMUSC is around 4 to 10, and normal transpulmonary driving pressure is around 4 to 8. And when the PMUSC is higher than 15, is a bad situation for the muscles, for diaphragm. And when we have a transpulmonary driving pressure higher than 20, is related to a lung stress too. So here we can observe patients with a negative inspiratory pressure from 8, the PEEP level from 8 to -2. So the patient mobilized 10 centimeters of water. So the transpulmonary driving pressure from 7 to -2. So in this situation, we have PMUSC around 7.5, then transpulmonary driving pressure around 13.6. A little video. In this situation, we have to observe the PEEP level that will be decreased up to -3, I think. The patient is in pressure support ventilation. I will do an expiratory pause to observe the occlusion pressure, and the muscular pressure was -3. I will wait around 15 seconds and do it again. I will try again. -3 again. So from PEEP 5 to -3 was 8. The occlusion pressure was 8 in this situation. To removing CO2, we have to increase respiratory rate up to 35 according to Brazilian guidelines, and another guidelines this is the limit. And if not enough, we can use tracheal gas insufflation, the TGI, but we know that there are no evidence about gas tracheal insufflation, and ECMO is more appropriate, but we cannot find ECMO in the great majority of hospitals in Brazil. So when we use ECMO, we have to use an ultra-protective ventilation with a tidal volume around 3 to 4 milliliters per ideal body weight. So according to the Brazilian guidelines, it was a suggestion, only a suggestion, that we can use TGI in order to improve, in order to decrease CO2 and to improve pH. This is an example of TGI. This piece is connected to endotracheal tube. Now we can observe ECMO, veno-venous ECMO. And to win in extubation, we will prefer pressure support ventilation or proportional assisted ventilation or NAVA, any ventilatory modality in comparison to TPs. We prefer to use ventilatory modalities to monitoring the patients. And in the past, we have afraid of the environment contamination, but we use this kind of winning in tracheostomized patients. So the environment is already contaminated. It's impossible to avoid this situation. We can do this technique proposed by an Australian group. So the mask over tube technique, we will extubate the patient with a mask and a filter. So when we extubate the patient, put the mask on the face of the patients with a filter. If patients have a cough, we are protected. And according to Brazilian guidelines, this is a nice study that we performed. We proposed passive mobilization and active mobilization with these patients. So we can do mulligan. This is a physiotherapy concept. We can do mulligan into the ICU. This is a mulligan concept. This is an approach to the knee. I will try to do a movement with the patient participation and try to use a glide, a lateral glide and rotation at the same time. Here I will try to mobilize the elbow of the patient with a lateral glide again with a belt. In this situation, I will fix the arm and I will try to do a lateral glide during the flexion of the elbow. Do the same thing. We can use neuromuscular proprioceptive facilitation, or another physiotherapy concept, focus on functional activities. This is a combination of movements. With agonic and antagonic muscles. For trunk control, I will change my contact. So it's important to trunk control before the upright position. So we try to walk with the patient into the ICU. I like to walk side by side the patient. Is the better position, is more safe. So it's important to emphasize that the patients have not a balance preserved in this situation. So we have to walk side by side the patients. I like to train this kind of movement for this. front and to the back. It's important. So to finalize, non-invasive ventilation, high flow nasal cannula are more used nowadays than in the beginning. And compliance seems to be lower than the observed in the beginning. I think that the near compliance or the phenotype 1 is rare. Pneumothorax is not necessarily related to mechanical ventilation. It can occur even in patients without mechanical ventilation. The PEEP titration should be done on electrical impedance. This is the gold standard, but it's not so viable. So we have to observe the lower driving pressure, or the best compliance is more protective than the PEEP table. Front position is even more used nowadays, maybe for 16 or 24 hours. And recruitment maneuvers in severe ARDS patients, but used with carefully. And when we have to prefer spontaneous breathing trial with pressure support ventilation in comparison to TPs. And mortality decreased. Thank God. For example, 88% in New York last year and 32% in Spain this year. So there are something difference between the last year and today, according to the use of non-invasive ventilation, according to the mortality. And we hope that in a few months or the next year, we have better results and even more patients without COVID. It's okay for me. Thank you.
Thank you, Sergio.
Corri pouquinho. I was fast because I'm afraid of according to the time.
No problem. It's very good presentation.
Would you like to make some questions, Bruno, or Paolo, or Carmen, or the audience? Quer fazer alguma pergunta, Bruno?
Vou fazer sim. Inclusive, tem muita gente aqui do Brasil, então vou até fazer em português, ok? Sérgio, você acha que manobra de recrutamento alveolar ou a mini titulação, ou melhor, que a mini titulação ela serviria para criar um prognóstico de potencial de recrutabilidade?
Uhum. Posso?
Quer falar, Carmen?
Então, o Paulo, você está entendendo?
Entendo. Um pouquinho.
Lá no Einstein, a gente fez um protocolo que a gente deixa o paciente na supina, aí a gente ajusta o PIP por essa mini titulação, aí se a PO2 e FO2 estiver menor que 150, a gente prona, e aí se não responder a prona, a gente chegou à conclusão que isso é o mais sensato possível. Se não responder a prona, por exemplo, você prona, a PO2 e FO2 ela não sobe 20%, ou você vê que o paciente, quando desprona, piora, aí a gente está recrutando em prona, porque assim a gente não vai precisar de tanta pressão, não vai precisar de pressão tão alta para recrutar, e a chance que esse paciente tem de reverter, porque depois que fica muito tempo no ventilador, aí não adianta mais. Então a gente tem feito precoce, com cuidado, obviamente, né? Então, mas a gente faz essa mini titulação na supina ainda para acertar a PIP certinha. Aí depois a gente prona, e se não responder a prona, a gente já recruta e ajusta a PIP antes de retornar à supina.
See, I agree with Carmen. In fact, in prona, one should reiterate, eventually try one recruitment with caution and the PIP. Another thing that it was not mentioned is fibroscopy. We use a lot of fibroscopy in order to clean the peripheral airways. I was thinking just on the case that Carmen showed, now that patient with on the right lung, and then the patient was prone, I think, this patient, and then he improved, no? This was likely an atelectasis due to some secretion or something like that. But again, probably not edema, because on the left lung there were no collapse. So in fact, also in the typical CT that Carmen showed, is not the real, like the RDS that we have in mind, no, with a progression, no, in the densities, and more or less symmetric, because is uniform. Here is very dishomogeneous. So also fibroscopy, I think, is very important to be associated with physiotherapy and positioning.
Bruno, se a gente encontrar uma PIP muito baixa, como PIP ideal, eu não faria o recrutamento, né? Eu não uso muito esse teste de recrutabilidade, eu tenho minhas dúvidas se em uma manobra só isso reflete o real potencial de recrutamento. Então, eu prefiro observar o paciente em termos tomográficos, em termos de complacência, né, que eu acho muito mais funcional, muito mais real. É uma manobra só, você diminui a PIP de 15 para 5 e observar se isso reflete o potencial de recrutamento. Para mim, né, na minha humilde opinião, não reflete completamente a realidade. Então, eu prefiro usar o recrutamento nos pacientes que têm realmente a complacência muito baixa, e como a Carmen falou muito bem, né, dos pacientes que têm a relação PO2, FO2 muito baixa, e a melhor posição para isso, né, uma boa combinação, como tem alguns estudos, é usar o recrutamento, né, durante a posição prona. Seria bem interessante, é bem interessante, por sinal eu gosto de fazer isso. Understood, Paolo?
Yes, understood.
Okay. I will try to speak slowly during my presentation. I speak so fast, sorry. I'm afraid because of the time.
Now, the other point that is a pneumothorax, very interesting. We had, I agree with you, I mean, most of pneumothorax we got even during those patients who were in non-invasive ventilation for a long time. Especially we had requests from other hospitals that they were maintaining, I don't know, 10, 15 days in CPAP, and then they start to get pneumomediastinum or pneumothorax subcutaneous emphysema. So they, of course, they had to intubate. They had difficulties. They referred to our center. Most of them, we decided to put at least first to echo-2R. So to reduce to remove the CO2 and to reduce the sort of we can say mechanical power, but I mean the injuries of ventilation, reduce tidal volume, as you say, no, ultra protective tidal volume, mainly reduce respiratory rate and tidal volume, so driving pressure and blah blah. But these patients are, now we are trying to, if we have time, because we have so many things to finish, but to collect the characteristic of these patients, but they were very hard. So when you start to get pneumothorax, pneumomediastinum, and this is, I don't know if you noticed, but usually if you look at the CT, what happens is it's very peripheral, these white areas like triangular, maybe infarct, I don't know what is it. And then it's not like the iatrogenic pneumothorax that we are used, is really the tissue completely necrotic. It's like a fistula, I mean.
Mhm.
In fact, it's very difficult. Even you have to drain, and not easy. It's not like the pneumothorax. We never seen pneumothorax anymore in RDS. No, very difficult with protective ventilation. While in this patient we started, but it is even before the mechanical ventilation. This means that is the transpulmonary pressure during non-invasive for longer period of time.
Mhm.
And also
Bruno.
most of patients with pneumothorax, at least in our experience, we also always look for aspergillosis. Most of them, they had severe infection with fungi, mainly aspergillosis.
Mhm.
Interessante.
So
Yeah,
that's good.
we had here in São Paulo a case of aspergillosis too, and cytomegalovirosis. And they,
Cytomegalo, we have not much. We had mainly Pseudomonas, actually, some Staphylococcus, and an increase in Candida auris, unfortunately, for COVID.
Mhm.
But Candida auris was not a major, so very few hemoculture positive. It was not so aggressive as compared to in case of Aspergillus or like that. We have not much Aspergillus, very few. But Candida auris, that you know, is considered, but in the reality from clinical, yes, you have the positive in the, in the here, but on the cutaneous, but not much aggressive in our opinion. It's bad because it's very widespread, so you have to take care a lot. But in terms of clinical effects, our experience was not so terrible. But antibiotic stewardship, as Carmen mentioned, in terms of sore infection, I think is one of the worst things of COVID. I think that we use probably too much antibiotics, too many antibiotics.
Here we are trying to avoid antibiotics at the beginning, because in the beginning, all the hospitals are giving the patient azithromycin and ceftriaxone when they enter the hospital. And nowadays we are trying to not give antibiotics at the beginning, only if the patient have condensations as the CT scan or clinical suspicion of secondary infection.
The problem here, this was a discussion with also with Bassetti, that is the chief of infectious disease in our hospital. Because this is true. In fact, we try to have a stewardship for that and some control. But the problem is that using corticosteroids, you increase, as you say, we also had data that we also published, that, as you say, the tolicizumab plus corticosteroids eventually we had very good results. This was almost 1 year ago. And but we have to pay that with a major increase in infection. So the question was if it was worthwhile to cover with some antibiotics the risk of overinfection due to the corticosteroids. It's a difficult balance, because if you start, for example, we used ceftarolone, which covered the methicillin resistant staphylococcus, due to the higher incidence that they found in China, like this, and then. So the balance to me is that if you use antibiotic, of course, you risk increase to have resistance, but you are almost sure that for 10, 12 days, you have no overinfection. So if you are able to go better within 2 weeks, you go without any infection. The problem is that if you have to, you are not able to extubate, I can say at 14 days, at that point, you increase the risk of infection. If you don't give antibiotics, the risk is that with corticosteroids in 1 week, you can get a overinfection. And so even just 1 week before the extubation. So it is a difficult balance. but it's an important question to me. How much and with which antibiotics, if any, to cover for sure, I will never use azithromycin and rochefrin. But this is an important question that has not been clearly investigated.
Are we having a lot of tetraparesy?
Tetraparesy not, but in fact I heard with interest what you said. But I agree with you that we have several neuromuscular disease, and in fact that was the reason why we prefer to limit the prone position, because you can limit neuromuscular blockade with corticosteroids first. Second, we try to go, as also was shown, assisted when possible. Of course, you have high drive with all the problems that we know, and physiotherapy. Physiotherapy was really essential. But even if we had patients with 6 months, when you showed that, we have even recently, even one patient, he was from Brazil. He's Italian, but he was from Brazil. And I had a contact, I did a phone call with Patricia, just to talk Brazil and Portuguese together. And his wife is in Italy. Anyway, he's in Italy since many years, but he's from an area near São Paulo, it was. He was 6 months with us, and then he was well. But physiotherapy, but we also found that after 1 month, I agree with you, 1 month and a half of physiotherapy, then we have a lot of photos, and then I have to download eventually to show the patient recover quite well. So, but this is an issue, yes, that delays the discharge from the hospital or quality of life, yes. But tetraparesis not. But for sure, neuromuscular problems, yes.
We have a lot of cases of tetraparesis. A lot of cases.
This is but did you do also, but did you perform electrophysiological analysis?
No, but the functional analysis
was poor.
Yes, grade 0 or 1 by
I think that there are
contraction.
two issues. One is the combination of these, according to the severity, how many days you have now corticosteroids and neuromuscular. Yes. The other problem, I think, is also nutrition. Nutrition is another issue that probably was underestimated in these patients. Now there are some papers new suggesting that really, as in other patients, but probably nutrition, we don't give calories enough in the weaning phase now. Also because it's not, we should give more, and probably, in fact, my feeling is not that we have debate in our unit. My feeling is that when we go to the weaning, we should give eventually some parenteral and enteral, because with enteral it's almost impossible to give the adequate calories. But we have discussion. This is my view, that in my opinion, for a certain period, we should give more calories and proteins.
Yes,
calories and proteins.
Sedation.
Yeah.
Sedation, nutrition, and neuromuscular blockers and corticosteroids are terrible for the muscle. It's so important, but are terrible for the muscles.
And that's why I think that physiotherapy in that phase has to be associated with good calories and protein. And to me, only nutrition by enteral nasogastric tube or even just eating is almost impossible to reach 2,500, almost 3,000 calories. Impossible. So my feeling is that probably I suggest sometimes to reinforce because we need more protein, at least 1.5 grams, almost 2 grams if there is no renal insufficiency, 2 grams per kilo, so almost 140 grams protein, so which is not, and at least 2,000 calories. So in that phase, plus physiotherapy.
Paolo and Carmen, it is so good to see two physicians like you talking about physiotherapy. This is so nice to observe. It's very nice for us.
But I
So
think
really,
that what we learned from we knew even before, but COVID, in my opinion, for the reason that we discussed, put in evidence the importance of this issue.
very nice. E Bruno, mais alguma pergunta?
I have one question to Paul. The patient that's staying in the helmet or in no invasive, how do you feed them? Because sometimes you don't know if you are going to intubate or not intubate. So
yes. We prefer in that case, usually we do parenteral. Yes. We give some through the enteral, of course, to the nasogastric. I don't know, means 500 milliliters, like that, and then we give parenteral. If we suspect that it might be intubated, yes. We don't give too much in that patients. When is in the ICU, if he's outside, they use parenteral. They don't give just a little bit 250, just for trophism, enteral trophism. But in fact, I can tell you that in the non-invasive, due to our organization, all the patients were treated outside the ICU. Very rare that we had patients in the ICU. Some, yes, but yes, in these last months, because we are more quiet. But in the real acute phase, all of them were outside. That's why when I see the paper on the helmet and non-invasive, yes, but they did that in the ICU. But the problem for non-invasive, if you do outside, not easy to do ventilator and helmet outside the ICU in the ward. But we prefer parenteral in these patients and just trophism for enteral. We are very cautious, yes.
Perfect.
E Bruno, mais alguma coisa?
Não tem pergunta da audiência?
Não? Quer perguntar não, Bruno? Você é o nosso perguntador oficial.
Não. Paulo, how do you see the future of the humanity?
Nice question.
I see that it will take time before we can meet again. Because I think now we are in a good phase, but I don't know what's the future. Because I think that the problem is that it's not a national problem or local problems. It's a problem, as you say, of the world. So I think that first of all, even if you are trying, I'm seeing here now, if you are trying to resume the normal, come back to the normality, you have a psychological bias, no? So now the mask, everything, the distance, it will be very difficult to come back. Even they tell you, oh, everything is fine, but psychologically, I think it's very difficult. Second, yes, we are vaccinated, but we will see. I mean, we don't know, no? Many things, variants, what happens. So anyway, psychologically, we have a problem. And third is that I think that many type of work will not be back again, like hotels, tourism will not be the same as before. So yes, you can do something, but not as before. Restaurants, very difficult to have meetings, for example, scientific meetings. I think that it will take at least 2-3 years before we will think to come back to normality. And I'm very worried about the global issue, no? Because even if you have your country, say, okay, now in our country we are going better, yes. But I just make an example for Italy. In 1 week, I think 10 days, they will open the border for Europe, no? So we will have free movement. And free movement means free movement, more and more other countries open. You come back to a difficulty. We were discussing why China is so good. Yes, because China, they closed everything, super control, quarantine, everything. So, and how long? So the real question, Carmen, I think about the humanity that you say, and I would translate, for how long we will have cases in the world, in some areas in the world, for a long time. So really, if I can tell you the truth, this is the same I discuss with the taxi driver every day when I go to the hospital, that we are discussing this kind of philosophical things. Perhaps I hope to be wrong, but I don't see a bright future. Bright future, I mean, I don't see that we will come back to the past, at least within 2-3 years. I hope it is not the truth, but unfortunately, this is. I think that I will have to wait a long time before to take a caipirinha together again.
Yes.
And this
Yes,
is not
but
good.
don't you think you need to educate more the people? Because, for example, in the hostel, we no, we adapt our work, and the health professionals can work in the middle of COVID, and everything is doing better than before. So
No,
we
no,
can. Did
Macar
you understand what I?
Carmen, I agree with you. In fact, as I said, I showed now what happened in the first intubation. We were like astronauts. Now we have it's very it's like other patients. We take more care of Candida auris than COVID now, no, in some way. No, I mean, what you say is correct, but I think is mainly in a very limited areas. No, in the hospital, you can improve. Even there is difficult, no, because you have different. Think only at the surgery, we had to create a lot of protocols for surgery, and positive and negative, and after surgery, they go there. So, which is not easy. But you can do that because it's a limited environment. What I fear is the normal environment, no? When you walk around. Yes, you can do education. Once is the education of professional, okay, working in a limited environment. One is the education in the population, because how to put together education with economical issues, many things. So I think it's
not easy.
Not easy, not easy. Politicians try to be very optimistic, of course, but I feel that there are so many problems that because now really in this year what we dealt with healthcare, mostly, and more or less in the hospital we were able to organize, but anyway, I don't know in Brazil, but for example in Italy we have a lot of delay in surgery, in elective surgery, how in the prevention of cancer. Many people, they don't come anymore to the hospital. So there are all the problems related to no COVID, and we did not solve that actually. And so I think that we are just at the beginning. We are so that we have to go back to the normality. So that we like the people that say, yeah, look, on July we can go to the beach, we can go to the restaurant, we can do everything. And this is what we want to listen, but I see also here in Chiavari, which is a small town, near Genoa, when they open, okay, all the bars are full like this, because people, they don't want to listen anymore about COVID. But unfortunately, COVID is around the world, is with us, it's not disappeared. So, and then I finish, but I think that this might be very dangerous, because we believe to have solved all our problems with vaccination, less infection, everything. But as I say, this COVID, now we know COVID very well, and this is when you feel that everything is going better, it is always back again. So it's something that I don't like and I don't trust. Till he will be dead somewhere in the ground, because so at the end I'm not so optimistic, but I hope that not in terms of people who, for sure, from healthcare system we will improve, we are managed better, but in terms of quality of life, I'm not sure that. To me, quality of life means to go back to what we were before. If you are not going back to what we were before, yes, okay, it's better, but it's not like before.
Paolo, only question. Can you talk about no invasive ventilation? What's the best strategy for this managing?
I agree with Carmen. I mean, what we used was that we tried mainly what we changed in this year is that we started mostly with helmet CPAP, and now we use at least 50% HFNO, high flow, and helmet CPAP. No, non-invasive helmet, no, I mean, impossible. What we try to do, of course, with some exception, especially in the high pressure, that when the patient starts to deteriorate, and we respiratory rate, the effort, all the things that we discussed, we prefer to intubate. Even recently, we had a patient, she was with helmet, she was at because we were not in the, we had no problems of bed in the ICU. And then we've seen that the patient was not improving. We decided to intubate. We did the CT scan, and the CT scan deteriorated. Then we started, and now the CT scan improved. So that's why I think that non-invasive is good, but when the patient starts to deteriorate, I think we have not to delay intubation when possible. That's why I think that the data of mortality like this are difficult to interpret, because it depends if you had no available beds in the ICU at the moment, which kind of patients, the age, so many things difficult to interpret that. But this was more or less our strategy. High flow now, this changed in this year. We did not use high flow at the beginning, also because we had so many high flow. This was the main problem. So high flow, non-invasive by CPAP by helmet, and intubation when the patient starts to deteriorate. At the extubation, this is something that there are one slide, but I did not discuss. Extubation, we use the non-invasive, again, high flow or CPAP, sometimes positive pressure at the extubation in those patients that are 24 hours, yes. So this was what we did in San Martino, in other centers. But I know in Italy, I can assure that 80% they use helmet CPAP, not non-invasive ventilation. This was just for the study, that's what I mean. I'm not critical for the study, but intubation rate between 50 to 30%, I mean, is too much difference, sorry, in 50 patients per group. Too much, 20% difference. And the other problem is that non-invasive positive pressure ventilation by helmet is not easy. I mean, you can do in intensive care, that's what I mean. And what I feel is that non-invasive is very important outside the ICU in order to save beds for the more severe patients in the ICU. Of course, if you have beds, you can do whatever you want. But to me, the non-invasive was the best method to avoid intubation outside the ICU, not as a treatment in the ICU. But this was our experience, I mean, in terms. For prone position and non-invasive, I agree with Carmen. We used also with this recent patient. She improved the lead, then she did some patients, okay, some patients, yeah, is something to be considered. But I don't think that it saves, I mean, it's something to be monitored. But always in mind, in my feeling, that when you use prone position in non-invasive, you know that can be good, but can also delay intubation. So then one can decide, no, but not only that is positive, that's my point, is positive and negative, and to balance the positive and negative. The risk to me is that some people, then they'll be, okay, you see oxygenation improve, okay, and so what? And then you go back supine, you deteriorate. The graphic that Carmen showed, no, this was one of the Italian study. Yes, they decrease the respiratory rate and improve oxygenation in prone, but when they reposition in supine, if you look, was exactly the same. Yes, some patient improved, some patient decreased. So again, not to delay too much intubation, because to me, this is the risk, the delay of intubation.
Thank you.
Tem uma pergunta no chat. O que fazer com o PIP na fase crônica?
I can describe the PIP.
Diminui.
The chronic phase.
Yes.
We keep around 8-10 centimeters of water.
Yes. Me too. We have the same. Yes. The chronic phase is when the patient does not improve within 2 weeks. The lung. That's why I think the tracheostomy is needed. In the if you start the chronic phase, you have to tracheostomize.
We agree.
Of course.
And to increase physiotherapy to avoid the neuromuscular.
Sure.
Physiotherapy is so important, and Paolo and Carmen likes a lot physiotherapy.
Yes.
It's too good, too good. Mais pergunta aí, Bruno?
But you know why probably physiotherapy was so relevant here? Because we were not used to use so much corticosteroids. So we used less corticosteroids, so probably all these effects that the virus per se is neurotropic, we know that, but I think that the combination of neuromuscular blockade, prone, and corticosteroids, that's why I would be, I mean, now people say, okay, we can transfer this experience to traditional RDS. Now, wait a moment, so because I don't know, I'm not so sure that we have to transfer the experience of COVID in the traditional RDS.
Makes difference.
Makes difference, yes.
Yes, of course. Minus corticosteroids, better muscle function.
Yes. Now, especially when you combine with neuromuscular blockade.
Yes.
We combined the worst, no? Corticosteroid, neuromuscular, and neuromuscular blockade at the same time. So.
E aí, Bruno, o que você acha aí? Tá bom? O que mais? Paulo, do you want to say something more?
I'm fine. Also, 11:30, and tomorrow I have to go
I'm
to the
fine.
hospital.
Oh, we forget that in Italy it's
in
five
Italy.
5 hours.
Yes.
Okay. It's okay. It's okay for you, Carmen?
Okay,
Para você, Bruno?
Ok.
thank you.
Very, 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 very good.
Buonanotte.
Buonanotte. It was a lovely discussion. I enjoyed very much.
Boa noite.
Paolo, thank you very much once more. Great pleasure. Carmen, muito obrigado mais uma vez, grande honra. Bruno, muito obrigado de novo também, grande honra.
Obrigado a todos.
Thank you.
Muito bom estar com
Obrigada a
vocês.
Obrigado.
Obrigada a vocês. Buonanotte.
Ciao.
Bye bye, Paolo.
Tchau.
Bye, Carmen. Valeu, Bruno.
Tchau, até
Valeu,
mais.
tchau.
Tchau, tchau.
Tchau a
Grande
todos.
abraço.
Um abraço.
Abraço. Tchau, tchau.